And now, another episode of Plastic Surgery Uncensored with your host, Dr. Roddy Raban. And I guess I'll be your sidekick. I'll be the sidekick.
It'd be my honor.
But this particular episode, I'm kind of involved in because we're going to call this one Implants Part 2, Part Deuce, like Hot Shots. And it might even be better than the original because I actually spent an hour with you talking about what I, in my mind, because I've been thinking about this for about 4 or 5 years, I lost about 35 pounds a few years ago. And I had a sag going on. And then I thought, well, I just need what I'm referring to lightly as a hooter hike. Hey, just a little hooter hike, a retread. You just, like a bra strap, you tighten them up. So last week I came in and spent an hour with you. Yeah. And man, I could not have been more off about it just being, it's work. Yeah, it's a lot of work.
Yeah, I mean, it isn't always a lot of work, but more often than not, it's a lot more work than patients think it will be in order to get an outstanding outcome. You got to put that emphasis in there. You can do anything you want to anybody, and depends on what your expectations are. If your expectations are, well, I have these implants, they've been in a long time, I want them out. That's easy breezy. That's a simple exchange. Literally, you make an incision, you take out the implant, you put a new implant, and you go about your business. That requires very little effort, very little knowledge, and you're not really doing much.
It's like a polish change at the mani-pedi salon.
Correct.
Okay, easy.
But the reality is that most women, when we're talking about revisional work when it comes to breast implants, two things have happened. One, their bodies have reacted to the implant over time. Not dangerous, but it's occurred. And two, their bodies have continued to age. Let's just say for a moment you didn't ever have implants. Let's not put all the blame on the implant. Your body would have undergone all of the same changes it underwent when you lost 35 pounds and you aged 5 years and so on and so forth, irrespective of the implants. The only difference is now we put a lot of that blame on the implant because you want them to look great. So you have to fix those things as well. So there's a lot that can be done or that should be done in order for you to look wow.
Well, let's start with, again, I always like to start at the basics, square one, pretend I don't know anything. When you have an implant, should you take them out anyway after a certain period of time? Is that just like rotating your tires? I mean, should they stay in? You put them in and that's it. Unless you have a problem, they stay in for life. Or should you take them out?
So that's a great question. It's a question that pretty much every woman asks herself or asks her OB or asks her doctors. And the answer is there's no right or wrong. It's just what's probably a good idea. So let me explain something. All devices, light bulbs, fan belts, all devices eventually break. They're made by a manufacturer. TVs, VCRs, everything eventually breaks. So the question then is what kind of person are you? Are you the type of person that likes to drive and only get gas when the light turns on? Or do you like to get gas when you see your tank is half empty and because you're afraid there will be no gas station and what if this is a better price and so on and so forth. So it's a personality trait. If you have saline implants, theoretically, you could ride them into the sunset, right? You put them in, you never worry about them, and you live your life.
If you don't get a flat tire, you're good to go.
So if they don't change, meaning you got older, they've changed, you had kids, you breastfed, if you think they look attractive and you have saline implants, theoretically, you could just leave them in. However, it is highly probable at some point in time that implant's going to rupture.
Highly probable.
Highly probable.
Above 50%.
For sure.
Oh,
okay, over your lifetime. So we usually say something between 10 to 15 years. That's a number that is considered reasonable before. And the goal is that you want to sort of get to your implants before they break. And this is the reason why. Not so much that it's not dangerous, it's not going to kill you, it's not going to cause a disease. What it's going to do is create a significant inconvenience in your life, and it's going to change the way you look. So if you have a saline implant and you are going about your life, everything's great, and it ruptures, you're going to wake up one morning and be like, oh shit. It's going to relatively be like that because they're saline, they're water balloons. The water deflates within 24 to 48 hours and you're going to notice a difference and your body will absorb the saline. It's gone. So the issue with that is it's kind of gone from something that could have been planned to something that's relatively urgent. Mm-hmm. It's urgent because you can't live lopsided. And what if you are on vacation? What if you're in the midst of something terrible going on in your life? What if you can't afford it? So the fact is now you're under the gun. And the reason why we suggest you change them is because when you change them under your
on your terms,
you have control over those parameters. So that's saline. Silicone. Silicone, if it breaks, it becomes a little bit more, it's a sticky situation. Okay?
Well, let me ask you something. I didn't even know what I had mine done. I know the day because I threw him a birthday party, September 17th, 1990.
Right.
I have had my implants in since September 7th, 1928 plus years.
And what did I tell you when I examined you?
You were very straightforward.
What do you? What did I tell you?
You were surprised that I hadn't changed them out.
No, but what did I tell you is probably happened to your implants?
Oh, for sure. You said they've ruptured. They're encapsulated.
Okay, so what I'm saying though is, so silicone implants. So let's talk about that.
Yeah, let's talk about that.
So silicone implants, if they rupture,
I didn't even know what type. You said you were very thorough, and you said they're likely silicone gel.
Okay, so silicone implants, if they rupture, then it becomes a little messy. Saline deflates. You got to change them. Silicone, you usually have what's called a silent rupture, meaning you don't necessarily immediately know. It doesn't deflate like a saline implant.
No, they look the same to me.
You kind of feel like everything's hunky-dory. And because it's a slow and gradual change, often you don't notice it. And what starts to happen is the silicone, so you have the gel, here's the implant. And for those of you listening, you can't hear. You poke a hole in it or it breaks. And the gel just slowly oozes out. And because the amount of gel present is still the same, it usually doesn't change the size.
So, but you measured me. All these things you talk about, from fold to nipple and nipple to clavicle, you did all that on me. And the symmetry was still pretty there. We were off like a half inch on one.
Yeah, this is not a
So did they leak equally?
No, that's not, again, we're not talking about, so listen carefully. Saline leaks, you get less volume. Silicone leaks, it's the same volume. It's not leaking anywhere.
Oh, it's
just gone outside of the implant. So your body is not going to notice a change in size. You're going to start noticing a change in shape. The silicone irritates the capsule. The capsule starts to thicken, and then that's what you start to notice. The first sign of a silicone rupture is usually not, you're never going to go up and be like, I think this breast is larger. That's not going to happen. It's the same number of silicone. You're going to start to notice, that's odd. I think my left breast seems a little different than my right. It's a little higher. It's a little tighter. It's a little more funny shaped. So silicone implants, the only way to know that they're ruptured is to usually do an MRI. Now, they'll find out sometimes on your mammogram, but usually an MRI is the only way to definitively tell. So we'd rather you didn't have them rupture, because when I go to take them out, and if you go on our Instagram, you'll see it, it's sticky. It's a gooey mess. And we'd rather not deal with that. Again, it's not going to kill you. The silicone's not going to hurt you. It's in a capsule, but it's a mess for your surgeon. So ideally, we'd like to remove the implants prior to them rupturing while you're driving on the freeway.
So my question, again, because I thought it was a simple retread, I don't feel different. I'm not asymmetrical. Nothing's hard. But you did a very thorough, and you said that I had encapsulation.
So I'm going to tell you about encapsulation in 1 second, because I forgot to tell you one other thing. Where the gummy bear implants come into play is if you get a gummy bear implant, the one advantage is you can ride them into the sunset. They're solid blocks of silicone.
That's for sure.
Don't ever have to change them. If they don't look bizarre, meaning you have no visual issues, they don't need to be changed, because but
if they move, you have to go in and put them back.
If they shift and they look bad, you can change them. But from the standpoint of them rupturing, they can't rupture.
Okay.
They're solids. Just as an aside.
So movement is their issue.
Yes. So now back to your question, encapsulation. So first of all, we have to define encapsulation. We'll keep talking about it in every case, because I think it's really important to understand. You put an implant in your body, pacemaker, prosthetic knee, heart valve. Your body knows it doesn't belong there. It's smarter than you and me. And it's going to protect you, because as far as it's concerned, it's foreign material. What it does is it creates a shell around it. It's scar tissue. That's called the capsule. Every single woman, every single human, everyone has it. The capsule is generally thin and irrelevant, and no one cares. You'll never know it's there.
Okay.
Some women, and for some reasons, and one of them is silicone irritation, their capsules start to thicken and get harder and more robust. It's not dangerous, but what it is it starts to change the way the breast looks and feels. You may not know that, because your breast,
I'm only looking down.
Well, you're also, again, this doesn't happen overnight.
Right.
This has happened over years.
Yes.
I, having never examined your breast before, can tell you that it's not as soft and as or normal as it ought to be. You to you is like same as yesterday, same as the day before, but it's probably not the same as it was, say, 20 years ago.
I'm sure.
And so what happens is that silicone, which again, I'm guessing in you, but it's probably highly probable, somewhere along the journey, your implant ruptured.
Okay.
The silicone started to ooze out.
Okay.
Again, you didn't notice any change in volume. and it started to irritate the capsule. The capsule started to tighten. And as a result, in your instance, the implants are sitting very high. And in addition, because you lost weight, your breast tissue, which is not connected to the implant, started to sag. So you have a separation between implant and tissue. Implant rising, tissue sagging, and that's where you're at. So in order to fix that, it's not a open, take out, put in.
No.
It's a open, take out, clean out.
And you were saying on the Instagram, on your Instagram, you have like you're scooping and it's
literally
a gooey mess.
It's gooey mess. So you got to get all that goo out.
Mm-hmm.
You got to take out the capsule.
Right.
You got to create, now sometimes there's pocket irregularities, meaning the shape of the pocket that was originally created is abnormal. It's either too small or too big and has to be corrected. Then after you put in a new implant and everything's in position, then you got to deal with the tissue around it. Now you got to do a breast lift to fix the tissue to bring it on top of the new implant. So when you're done, your breast and implant are one and the same.
And you went into deep detail, and I'm going to do it. We talked nipple for a long time. There was a lot of nipple talk.
Well,
and that was pretty, number one, at this moment in time, I have all the normal, what we call, headlight functions. If it gets cold, But you said that with an additional surgery, I'm running the risk of loss of sensitivity or worse.
Yes. So when you if you're having a primary breast, so now let's change gears. We're moving out of implants. Mm-hmm. Moving out of rupture, moving out of capsules. Now we're dealing with what the hell do I do with my breast if they're sagging? Because it's a separate issue. So whether or not if your breasts are sagging, 90% of the time an implant's not going to cut it. An implant doesn't lift your breast. Very rarely, if it's slightly sagging, a large implant will fill the envelope. But 99% of the times, if you're sagging, you're sagging. You need a lift. Whether or not you
can't just hike it up like a bra strap.
No. So whether or not...
Wishful thinking.
No. Alternative universe. So what happens is you need a lift, and lifts basically mean tailoring or removing the excess skin that has led to the poor shape. So they come in different shapes. There's one that's called a donut. We cut around the areola, pigmented area, and remove the skin. We have one called a lollipop. We cut around the areola and down the middle of the breast. And we have a third one called an anchor, around the areola, down the middle of the breast, and along the crease. The lift you need is not the lift you want. The lift you need is the lift that your measurements dictate. In other words, you don't walk in and say, oh, I want a donut lift. Your surgeon should tell you what lift you need.
Well, everybody just wants the little
Of course,
guy.
Nobody wants incisions and scars and things like that. Now, what we were talking about is when you want to lift up the breast, what does lift mean? It means lift the nipple. That's what it means. It means that your breasts have sagged. And in addition to having contact between your skin and your chest, your nipple is pointing down. It's fallen. And where you wish they were is in the middle of your chest. So we have to lift your nipple back up. We do not cut your nipple off and stick it back on like a sticker. It will die. So the way to lift is by rearranging blood supply. And in that process...
So there's let's just simplify it. So there's pipes, straws of blood that go to your nips. But there's not just one pipe. You've got to, because of how sensitive, you got a lot of pipes.
Yes. And you have to cut some of the pipes and leave some of the pipes.
Okay.
So if you cut all the pipes...
Bad.
Bad. What will happen if you are too aggressive or remove everything? One, you will lose sensation to your nipple. But much worse, you will lose your actual nipple. It will die. It will gangrene. It will necrose.
Ugh. I can't even imagine.
So when an individual...
Have you seen that?
Not on my own patients,
no,
but I've
I'm
had
saying
yes,
you had people come
yes. I've had people come in a week after their surgery and
with a dead nip.
Correct. Ooh. And then you're into the breast cancer reconstruction, making one that's not real, etc. Where the risk increase is if you've had a previous lift. When you've had a previous lift, that means somebody cut some of those straws, and now you're asking someone to cut more of those straws. If you smoke, much higher risk. If you're a diabetic and you have poor arteries, higher risk. If you have heart disease, higher risk. We're talking about survival of the nipple. So we move from implant to capsule to now lift. And within the lift, we're talking about the survival of the nipple when we do the lift.
And okay, when you do lifts, let's just say a garden variety lift. Is there a garden variety lift that doesn't involve the encapsulation and the just regular somebody comes in, I've lost weight, I've aged, I have implants, I don't have all these other things that I came to you with after 28 years. I just want them lifted. what is the survival rate on those nipples? It's
Well, I mean, the survival rate in general is pretty good. If no one's ever had a lift before, it's usually, let's say the death rate of a nipple is probably less than 1 or 2%.
really.
Yeah, it's very rare. So it's not a major issue. It's just a matter of making sure that you take care of all the moving
It's very
parts.
low.
Yeah, in general, it's very low.
And if somebody's going for a second lift,
Then it increases. Nobody knows these statistics because
But-
it's not,
but
it's higher. Let's say 5 to 10%.
okay, that's still not horrible.
Yeah.
All right, good. I'm just asking for me.
Yes, I know. Okay, you'll be all right. We got you.
Okay, excellent. When we're going to take a break, because when we come back, I want to get back to the very specifics, because women do think that it is that simple, that taking them out is simple or a hike is simple. And how frequently do people come in and they have to have so much more than they thought? Like in my case, I don't want you to answer now, because I think the answer is going to be pretty surprising. We're back with Plastic Surgery Uncensored, and I asked Dr. Radi Rahban a question before we went to break, and the question was, because it happened in my case, like I left here like, how often do people come in here because of social media and pop culture thinking, hey, I'm just going in for a hooter hike? They come in here expecting it to be very simple, and once they leave here, you have educated them, and it is way more than they bargained for.
Listen, unfortunately, it's the majority of patients.
I knew it.
Listen, this is the problem. The problem is that most patients obtain their information initially from friends, online, and through social media.
100%.
So what happens is that you're out there, you're like looking at yourself, whether it's a man or a woman, and you're like, God, I hate my eyelids. I don't like my ears. I hate my nose, whatever. And then you start this process organically on your own, and you start chit-chatting.
You're on FaceBack.
Yeah,
Who else hates their eyelid?
you start chit-chatting, and then you realize that, oh, okay. And it's always going to be much more minimal because the people you talk to don't ever give you any detail. They're not doctors. You go on social media, and it's usually just journey related. Oh my God, I had my so-and-so done. I'm amazing. And then unfortunately, what ends up happening is a lot of the physicians, a lot of the doctors, for two reasons, minimize what really needs to get done. One is they don't have the skill set to do the entirety, or they don't want to. Or the other is they're afraid that if they tell you the full Monty, which is the right thing for you to do, you're not going to book. See, when you come to my practice, as you experience, I have one objective, and that is to tell you what is going on with your body and how you need, what you need in order to get an amazing outcome.
Amazing outcome was the key.
Not okay outcome. Not it'll be. So one of the things I hear all the time for revisions, my doctor and I decided this should work, or it'll be good enough, or I can get away with. That dialogue doesn't occur with me. So here are your
No, it does not.
Here are your options. All of the following options are not good options. This is your best option. So the problem and the frustration that I have is I spend a lot of time with patients. Usually by the time they get to me, they've already gone to a few places, they've been online. And it's a lot of re-educating and sort of arguing and struggling because they're like, not sticker shocked, but like, oh, but I was told I don't really need a lift. Of course you need a lift. You're going to have a terrible outcome. Oh, I was told that I don't really need my septum. I don't need cartilage for, like, it's constantly this educational process. And the reality is that some patients get it like you did. And you're like, oh, wow, this makes sense. Oh my God.
I'm not going to lie. I was shocked and scared and horrified, but in the best way.
No, but the question is this. Did it make sense?
Oh, my land. I left here. I actually emailed your nurse to say in my life, whether I had LASIK surgery, I've had skin grafts, I've had surgery in my life. I've never had a physician explain exactly, specifically, I'm going to do this, this could happen, I'm going to do this, this could happen, you absolutely need this, there's no way we can't do that, this is going to be like this. I mean, and maybe because I know you, but you were so specific, it's like, oh, that's going to be a damn disaster, I'm going to have to pull this out. And you like...
I'm that with everyone because what everyone needs.
You said it was going to be like 5 hours.
It will be 5 hours.
I thought it was just going to be a we're out.
No, what everyone
5 hours.
What everyone needs, or what everyone should hope for, is that their physician and them, the relationship they have, is very authentic, and that authenticity is that I'm going to tell you the good, the bad, and the ugly, and then you and I together will figure out how to handle this. But the idea that I'm going to tell you, I'm going to dumb it down because I don't think you can.
No, you did not. You used words I didn't know right. Encapsulate. Like this is a lot.
But that's the problem. And as you asked me, I would say the overwhelming majority of patients, unless they've done homework on my site or they follow me and they know the dialogue, for the majority of patients.
At Radi Rahban.
So yes, but it's our duty and it's a fiduciary responsibility to make sure that they get the information. And so we do that in the consult.
Well, I left here thoroughly consulted, very excited.
Hopefully not thoroughly insulted, but consulted.
Not insulted, consulted and excited. And I have to tell you, it's the way you said it at first was a little bit like, whoa, because you don't minimize anything. You went into every possible down, and then we talked the up, and the up was way much better. Yeah. So that concludes another episode. We're going to call this one Implants Part Deuce of the Plastic Surgery Uncensored podcast with Dr. Radi Raban.